prominent faculty for it from the USA, and few more faculties from the Philippines and where. And I would like to
physically as well that the channels the spins have cut, they are parallel to each other.
So now I will hand over all the flow of the session to this moderator, Dr. Nikesh and Dr. Malhar. Over to you.
Yeah. Thank you, Sejal. Let me have an opportunity to introduce Dr. Selene Parekh, who is Director of Digital Strategy and Innovation and Professor in the Department of Orthopaedic at North Carolina Orthopaedic Clinic. He is also an faculty to Fuqua Business School, Duke University. Dr. Selene and his wife runs Parekh Family Foundation, who does innumerable charitable and educational activity in third world countries, including India. And Dr. Selene Parekh is credited to perform first total ankle replacement in India way back in 2012. And almost every year he is doing ankle replacements in India in the foot and ankle.
Long way in
Foot and ankle orthopedic surgeon, Dr. Malhar and Dr. Nikesh. So now I will hand over all the flow of the session to this moderator, Dr. Nikesh and Dr. Malhar. Over to you.
Yeah. Thank you, Sejal. Let me have an opportunity to introduce Dr. Selene Parekh, who is Director of Digital Strategy and Innovation and Professor in the Department of Orthopaedic at North Carolina Orthopaedic Clinic.
I think it is still not, sound is not there. I think it is still not, sound is not there. Alpesh, who is sharing the screen? I think it is still not, sound is not there. Alpesh, who is sharing the screen? I think it is still not, sound is not there. Alpesh, who is sharing the screen?
Sudeep bhai, please share the screen, please.
Yeah.
Okay. Fine, got it.
travel, but hopefully in the next year, we'll be back to India. So I've been asked to talk about total ankle replacement and going on and all the restrictions on travel, but hopefully in the next year, we will be back to India. So I've been asked to talk about total ankle replacement and an update on ankle replacements. Let me see. All right. Are you guys able to see my screen?
Yes.
Yes.
Perfect.
Yes, yes.
So, total ankle replacements have come a long way, and we are now in the 21st century where we have access to electric cars that look like Falcons and can go hundreds of miles between charges. You're able to wear smart glasses that allow you to do things on voice command. We have smart contact lenses that can to monitor your glucose levels. We have smart spoons that for the Parkinson's patient can help stabilize their tremors, and you have smart t-shirts that can monitor your vital signs. And then the smart watch. So we've come a long way into the 21st century with technology really advancing the things we can do. So why not have total ankle replacements that can allow athletes and individuals be more mobile, to be more active into their later ages, even after they've had ankle arthritis due to traumas or due to rheumatoid arthritis. Let's give these individuals an opportunity to have motion. So why total ankle? Well, severe painful post-traumatic ankle arthritis is extremely painful. And in fact, there's data to suggest that end-stage ankle arthritis is as severe, if not more severe, than end-stage hip disease. We need solutions for these patients because these patients suffer from debilitating pain. They can have large bone loss. They can have other adjacent joint disease. They can have bilateral involvement. And we're looking for solutions that provide them with pain relief and preserve motion and stability. And so you have patients that look like this who have end-stage ankle arthritis, or like this who have post-traumatic ankle arthritis, or even like this who have varus ankle deformities or valgus ankle deformities, and they are looking for opportunities to maintain their quality of life through preserving joint motion. So the indications for ankle replacement are really in the optimal patient. When you first start out doing ankle replacements, that optimal patient has less excessive demands, and they tend to be the rheumatoid patients, the older patients, the post-traumatic patients, who again tend to be over the 60-year-old mark, or those patients who have multiple joint disease. However, as you get more comfortable with ankle arthritis and total ankle replacement, you will expand those indications. And now at our institution, and including in my practice, I've done teenagers who have ankle arthritis because we are comfortable with the revisions that may need to happen in their life. So the relative indication are the youthful active individuals, and the contraindications traditionally are talar avascular necrosis, Charcot joint disease, neurologically compromised foot, or patients who have chronic infections. Now, end-stage ankle arthritis can be very complex, right? You have patients who can have the straight ankle that are properly aligned, and those patients who have malalignment. And in fact, about 37% of patients only have normal alignment with ankle arthritis. The rest will have some type of deformity that you need to be able to correct. So you have to be able to and be comfortable to do adjacent joint or adjacent or concomitant foot and ankle procedures to help balance that ankle when you do the total ankle replacement. You've got to appreciate the deformities both on the AP view with varus and sagittal view, where you can see sagittal malalignment where the talus can be subluxed anterior or posteriorly. So how do we do these ankle replacements? Well, here's a 360-degree camera of the setup in my operating room, and it's got a lot of individuals in there, not only the surgical team, but we also have the team from the companies, or the reps as we call them, to help support the case. And then you've got the sterile back table, which has all of the sets open for whatever we're thinking about doing. Now, when we look at ankle replacements, we've come a long way, and it's evolved. When we first started doing these, you had these these half ankle replacements that had a poly on the other side, which had tibial component loosening over time, and as it loosened, the talus could rattle and end up with a malleolar fracture. And in the last generation, so before the latest generation, you have, and you still have globally, but you had implant companies who had these total ankle replacements that respected the anatomy more, but still took quite a lot of bone away from the joint. And when that happened, you would struggle with revision type surgeries. So the common issues we saw in the previous generation, right before this latest generation, were tibial trays causing fibular impingement because these were not anatomic implants. You have a limited ability to restore sagittal alignment, that talus that's anterior posteriorly subluxed. You really couldn't do much with it except for releases. It took too much bone away, so these were not bone sparing devices, and so you worried about injury to the talar blood supply. We had difficulty with talar loosening on the talar side, and you had this cumbersome instrumentation that made it difficult to put the ankle replacement exactly where you wanted it, which is important for ankle replacements to get the alignment that you need. So impingement, why is this important? Well, because you have a right ankle and you have a left ankle that have incissuras that house the fibula. And so you need to have an implant right and left that allows you to recreate the anatomy to house the fibula. Because if you put a rectangular device into the tibial tray, you will impinge that fibula. And so the latest models are more anatomic, they're fixed bearing, minimal bone resection. They keep the instrumentation simple, but allow the surgeon to be able to place the implant exactly where they want them. And we believe that these are reproducible outcomes for in the long term for patients. This is the Cadence ankle replacement and allows you to have 670 different combinations of talar component, poly component, and tibial component to allow you to give the patient a custom implant without really having a custom implant. And it allows you to also have biased polys, which this was the first implant on the market to allow you to do that. It also had a tibial tray base plate that had that incisura, so it was more anatomic and respected the fibular anatomy. It also had some other features which allowed you to upsize or downsize the implant without having to worry about new peg holes that you're making or new holes in the tibia or in the talus that made you fixed to one size. And that's important because if you're in the operating room and you think this patient needs a size 2 and you start putting the trials in and you realize, wait a minute, it's a size 1 or it's size 3, you should have that flexibility to be able to upsize or downsize the total ankle as needed. And so again, the tibial base plate has this incisura, and so this is what this implant looks like on X-ray. Again, like I was saying, the poly, this is the first system that had a poly that was biased, either anteriorly or posteriorly, to help fix that sagittal alignment, which some papers suggest can be upwards of 30 to 60% of total ankle replacements can have this sagittal malalignment. And so to have a poly to be able to push the talus back or pull it forward, whatever the case may be, is important. So you want to get that alignment, the center of the talus, you want to get it back underneath the tibia where it belongs. And so here's a case where we are able to use the poly to pull that talus back into the center of the tibia. And then you have to do some concomitant procedures to help get the alignment that you want. Here's another implant. This is the Vantage Exactech implant. Again, it's anatomic, fixed bearing, minimal bone resection. It has axial pegs that go into the tibia, with the presumption being that this also will allow for better fixation into the tibia. It allows also for acceptance of the incisura by just having a mild curvature to the tibial tray. So again, it allows for a more anatomic fixation. Again, it has these vertical cages that are fixed into the tibia. So those are the two newest implants that are on the market, starting to percolate globally. But when you look at in the US, the total ankle market, it is full of total ankle replacements that are currently on the market, with new ones that are coming out later this year and even next year. So it is a very crowded space for a small volume of cases. The outcomes for total ankle replacements we know is very good. Patients are better with an ankle replacement than ankle fusion patients when walking up the stairs, walking downstairs, walking uphill, and that makes sense because you have ankle motion. Total ankle patients have higher rates of satisfaction and better biomechanics of gait than ankle arthritis patients that are fixed with fusions. The bilateral gait mechanics are much better with ankle replacement patients. It's closer to normal with ankle replacement patients than with ankle fusion patients. The pain relief is the same, equal, ankle fusion versus ankle replacement. But again, total ankle replacement patients at 2 years have better gait, better mechanics, better pain relief. So for me, ankle arthroplasty in the young is no longer a relative indication. I think the benefits of range of motion, pain relief, activity level when younger is much more critical than than fusing them when they're younger. And then when they're older, trying to take down that fusion and give them an ankle replacement. To me, that doesn't make sense. And that used to be the prevalent school of thought, that you fuse them when they're early, you take it down when they're older. And when you fuse them, you no longer move the muscles that are in and around the ankle. And so as they get atrophy to 10 or 15 years later, then try to take down the ankle replacement and try to give patients motion again really never made sense to me. So here's one of my patients who in her early 20s got an ankle replacement. She is now in her mid 30s, and the left ankle is where she had the ankle replacement, and you can see it still allows her to be fashionable, wear the shoes she likes, and she also is able to run, although against my medical advice. So, I told you avascular necrosis is a relative contraindication, and only recently has it become a relative contraindication. You have a patient who has ankle AVN like this, and in the past, they were either told that they can only get non-surgical treatment with some type of ankle brace, or that they can get a TTC fusion, which was fraught with non-unions, anywhere from 30 to 60% non-union rate of one of these joints, either the ankle or subtalar joint for TTC fusion in the setting of AVN. So the challenge of AVN is that it's hard to treat. 75% of the time, AVN is due to trauma. 90% of talar neck fractures go on to develop AVN. And this has actually become, at least in the US, a little bit more of interest in the last few days because Tiger Woods, unfortunately, had a serious injury to his lower extremity. One of those injuries was a talar fracture. We don't know if it was talar neck or body, but the point is it has elevated this discussion in the US temporarily in AVN. 25% of atraumatic patients, 25% of AVN patients are atraumatic, and that can be due to sickle cell disease, exposure to corticosteroids at some point in their life, patients who've had a failed ankle replacement who developed AVN of the talus and then led to an ankle replacement failure. And then you have your idiopathic cases where we don't really know why they're developing AVN. So the indication for a total talus is patients who have talar AVN, talus non-unions, talar collapse after ankle replacement, patients who've had subchondroplasties done. This is a product that is in the market where we used to believe that if you had talar edema, you could actually stabilize that talar edema with calcium phosphate. What our group has noticed and has now published is that oftentimes these patients end up with talar AVN because that calcium phosphate has choked off the blood vessels in the talus and now led to talar AVN. The relative indication for total talus is a youthful, active individual, but I'll share with you some cases that we've done in up to 14-year-olds. And then the contraindications are the same as total ankle replacement, the Charcot patients, a neurologically compromised foot, or patients who have chronic infections. And so here's a 19-year-old girl who had a CML as a young teenager. She was exposed to prednisone as a young teenager. 5 years later, she has AVN and continued pain bilaterally. And you can see on this MRI, both up on the upper left as well as the lower right, that she has significant AVN, not only in her talus, but distal tibia, and even somewhat in her calcaneus. And so the father lives in another state, finds us on social media and realizes what we're doing, reaches out to me and says, hey, is there any motion sparing option you can provide my daughter? So here's a total talus that we are planning on CAD drawings. And how we do this is same thing as an ankle replacement. We go in through the standard anterior approach. we take a wedge out of the talar neck. And so that separates the body from the head. It also disrupts the interosseous ligament. So now that the body and allows the body and the talar head to be loose and mobile. We then go ahead and take the talar head and then the body to the left. And when the first time you do this, it is amazing to look at the anatomy of the posterior facet and the calcaneus, which is a view that most of us have never seen before. And then we have these trials. So using a CT scan, the company can print out the exact replica of this patient's anatomy, either using their affected limb if the anatomy is intact, or using the contralateral side if the anatomy is not intact, and then obviously doing a mirror image to provide the talus. And so you have these trials of the normal size talus, and then we also have 10% decrease and 10% increase in size. And so we get a tray with these trials and the total talus, which used to be silver, which was cobalt chromium, and now we have an option on these gold ones that are titanium nitride, which we believe wears better against the cartilage. And when you put these taluses in and you have the right size, it's almost like a bipolar hip, where you hear the thud, you'll hear thud into the joint, and that's when you know you have the right size. And if you look at this motion, I mean, this is an unparalleled motion, whether it's for ankle, total ankle, you just don't see this type of motion. And it's pretty remarkable what these patients can get back. And so, you know, we initially started doing this on patients who had restricted AVN in the talus without associated adjacent joint arthritis. But then we started getting more sophisticated, and I started getting a little more bold, taking on those patients who had AVN who also had ankle arthritis. And so here's a patient who came in to see me from Hawaii, and he has bad ankle arthritis, a sublux talus, and also avascular necrosis. But we can now take a total talus, take care of their AVN, put in an ankle replacement. So this talus is matched to the total ankle, and allow us to replace his ankle, give him a new talus. He maintains motion, gets pain relief, and actually has an active life. This is a patient who is now 3 months out from her total talus, and against my advice, started doing box jumps. So this is jumps where you're on the floor, you jump up on a box, you jump down on the floor, you jump back up even higher, you jump back down. So she's doing impact activities, which we don't want these total ankle or total talus patients to do 3 months out from surgery because she's feeling so great. It's pretty amazing to see these patients function. Here's a patient who has AVN with ankle arthritis and subtalar arthritis, and we can now do total taluses with an ankle replacement with subtalar fusions. And so we're getting more and more sophisticated as to what we can address. Here's a patient with AVN, subtalar arthritis, ankle arthritis, but also a varus deformity, and a fixed varus deformity. And she came in to see me and said, Dr. Parekh, either you amputate me or you do something to salvage my motion. And so we did a staged procedure where we put on an external fixator. I cleaned out the talus, actually put a spacer in. Her talus looked a little questionable. It turned out she had a subclinical infection. So we cleared that. And then we did this total talus ankle fusion, ankle replacement with a subtalar fusion. Now, her alignment's much better on the sagittal view, but you can see that her talus is a little bit plantar flexed into the calcaneus. But she has a limb, she's walking, she's able to be active, something that she could not do with her varus AVN ankle arthritis. Here's a patient who had a triple arthrodesis done by me. He then developed ankle arthritis, so we ended up doing a total ankle replacement. And then I usually like to see my ankle arthroplasty patients every year. Well, this patient got lost to follow-up, which usually means they're doing so well and it's inconvenient for them to come see you. He lives about 3 hours away from me by flight. And then he shows up 7 years after his surgery. And you know that when you haven't seen a patient for a while and then they show back up, it's usually a bad thing. So he comes in to see me, and if you can look at that talus, you can see the talus has collapsed. He has developed talar avascular necrosis under this ankle replacement. And so we can use 3D printing to create a brand new total talus, which has an undersurface that allows for a fusion to still occur, so we can maintain the correction we got on a triple arthrodesis. And he has now salvaged his motion. He's back to playing 18 holes of golf 3 to 4 times a week. He's happy. and I haven't seen him again. So it's usually a good sign, like I said. This is a patient, a sad story. This is a girl, and this is not Tiger Woods' car. This is a girl who lost control of her car, hit a wall, and ended up getting extricated from the car. They lived about 6 hours away from Durham, where I'm located. And the girl is 19 years old, was taken to the emergency room, had bilateral injuries. On the left side, she has an open talus that is extruded. The talus was extruded. On the right side, she has a pilon fracture. So the trauma team in this hospital puts her in the X-fix on the right side, talks to the mom about primary amputation. The mom begs them not to do it. The next day, returns to the scene of the accident, finds the talus bone, and brings it back to the surgeon, who now says, listen, there's nothing I can do with this talus because it's been extruded for too long. So she comes in to see me, has a cement spacer in, and mom is told it's an amputation that this girl needs. The mom gets on the line, finds us on social media, what we're doing at our institution, brings the daughter to us. And not only, if you look carefully, not only is she missing some of her talus, she's also missing the medial malleolus. So, and she's got an open injury. So we end up clearing the infection first. And while we're clearing the infection, we maintain the external fixator, but we also start designing a new medial malleolus for her, as well as a total talus. And so this is the medial malleolus that we are creating. And it has a stem as well as a plate. The plate will allow us to put in screws that go from the plate into the stem. This is her total talus. And so she now has a 3D printed medial malleolus as well as a total talus. She's now 21 years old, has a limb. She's able to date. She can get dressed up. Things that are important for a 21-year-old to live life in a meaningful way. She's now able to do rather than having an amputation and prosthesis. Here's a patient who came in to see me from about 8 hours away from our institution, has this bad injury that's treated locally by his surgeons. So he gets this plate, gets the pitting of his talus, ends up with this modeling of the talus a few months after his injury, comes in to see me. He's got an elevated ESR CRP. His white count is not elevated at all. This is a three-phase bone scan showing a hot area in his ankle, so he's infected. So we have to go in and clean out this infection with a cement spacer. He grows out Propionibacterium. We clear the infection, but if you look here, he now has some subtalar disease, ankle disease, as well as talar navicular disease. And so we can, with 3D printing, I think I've showed you that we can do some really amazing things. And so he was my first total talus with a subtalar fusion and a talar navicular fusion with our ankle replacement. So we do a lot of biologics around the ingrowth surface of the talus. We've got this fixation. This is what it looks like in the operating room. This is what it looks like under fluoros. And we have been able to get him back to work. He's about 1.5 years out from the surgery, has 1 to 2 out of 10 pain and has done well. So we always hear, we're an academic institution, we're interested in looking at the data, and we always hear, how these patients really do. So our first paper, we wanted to look at patients who've been about 12 months with their total talus, but we wanted to look at if we really restore their anatomy. So this is our first 14 patients, and a lot of these talar AVN patients collapse, so they lose their height. And so we know that now through this paper, we know that we can restore their height. This is statistically significant. And we can also restore their talar tilt. So as they get collapsed, you can imagine the plafond, the talus can start getting malaligned. And we can restore that through the total taluses. And that makes sense. And this is statistically significant restoration of their anatomy. So from this data, we know that taluses can restore anatomy. And they can allow us to have viable options for patients who have talar AVN. But what about their function? So this is the first 15 patients of ours that passed the 12-month mark, patients who have talar AVN. And we look at their preoperative foot and ankle orthopedic scores versus their postoperative. And you can see here in the green bars, every single green bar is further beyond the blue bar, which means their pain, their symptoms, their sports and recreation activities, their activities of daily living, and their quality of life metrics have all improved that are statistically significant. And now we've started looking at our 2-year data. All right, so these are patients who are now past the 2-year mark. The average is 22.2 months, and the mean age of these patients is 43 years old, who have AVN. Their ankle range of motion is post-op is similar to their pre-op, but I'll tell you that I think that this is probably not accurate, because when I see them, they have better motion. We've done adjacent and controlling procedures to help get them some of that motion. More importantly, their visual analog pain scores have improved, and this is statistically significant. So if they're living on average at a 7 beforehand, after surgery, they're at a 3. Most are, I'll tell you, at about a 1 or 2, but the average is about a 3. Their FAOS scores continue to be improved from pain, symptoms, quality of life, their activities of daily living. So we know now, and we will continue to track this, that total talus patients who are using the total talus to treat AVN and adjacent joint disease have significant improvement in all metrics that we've looked at, have better anatomy. We are going to continue to follow this patient population. We are now over about 100 of these patients in our database, more than any other place in the world for 3D printed total taluses. But again, this is the tip of the iceberg. We're offering options where patients didn't have options before, and we're giving them hope. With marrying this type of technology of 3D printing with total ankles, we have something that's reliable. Total ankles alone have excellent survivorship. They have pain relief. This is a versatile solution for this patient population. But again, the future here is going to be 3D printing, really giving these patients very anatomic solutions for their disease states. Thanks.
Yeah, thanks, Dr. Selene. Now we have our next speaker, Dr. Michael Dujella. He is a board-certified foot and ankle surgeon. He is a national chairman of the Education and Civic Affairs Committee for the American College of Foot and Ankle Surgeons. He is executive of the Global Foot and Ankle Community, and he is a surgical faculty Providence St. Peter Family Medicine Residency Program. And he'll be talking on newer dimensions of management chronic foot and ankle disorders.
Thank you. How do I share my screen here with you all? Welcome. Can you hear me?
Yes, sir.
Yeah.
Thank you. Thank you very much. How do I share my screen with you?
This green button, share
The
screen.
green button? Okay. Let's see here. Pleasure to be here. I'm sorry I'm on a few minutes late here. I had a little bit of confusion with the time and just came back from the hospital. So we're glad to share this with you. I'm going to talk a little bit. Can you see the slides now?
No, sir.
No.
So an alter plus S will share your screen, Michael.
I'm sorry?
Alter plus S.
Alt S.
Alter plus S. If you press this, your screen would be shared.
Can you see that?
Yes.
Yes. Yes.
Okay. How about
Just
that? Perfect?
Yes, Dr.
Perfect.
Okay, very good. Thank you. Thanks for being patient with me. Rajiv Shah has asked me to talk. I'm pleased to be with you in the Orthopaedic Association in your city, and some very fine faculty from the Indian Orthopaedic Foot and Ankle. I'm very pleased about that affiliation we've garnered over the last few years. I have a huge amount of respect for the work that you're doing in India, and made many friends with you all, and I hope to see you again in person soon. So I'd like to talk a little bit about some techniques in foot and ankle surgery. And here in the US, one of the things that I've been asked to talk about that I think can be of interest eventually in India even is amniotic membrane use. This is a technique that we've had around for a few years now, is becoming a little bit more available in hospitals, but can be a bit costly in the United States. So some areas that we can't get equal access to this. What's the role of amniotic membrane? in surgery, and what does it really mean? How do we implement this into orthopedics, and what other areas of medicine has it been used in? So amniotic membrane essentially is tissue that's been electively donated, and this is not coming from the fetus itself, it's from the maternal placenta. And what's unique about the biology of this is, of course, fetal tissues are not equal to adult tissues. And so as we look at the wound healing cascade, this concept of fetal scarless healing. And the problem is when we see this change us to getting into more of the young child or adult, we go from this phenotype where we have a scarless to more of a scarring and an adhesion phenotype. And that, of course, correlates directly with inflammatory reactions. So as we see decreased inflammation, we know we have decreased scar formation. That's one of the areas that becomes very influential when it comes to revisions in foot and ankle surgery, because, of course, some of what we're doing involves revisions and complex tendon. So as we disrupt this inflammation by using fetal scarless healing technology, using these amniotic membranes, we see decreased kind signaling, and we decrease the lifespan of these protatory cells, which is very important, which of course also decreases the proliferation and infiltration of inflammatory cells. So what are the specific advantages of fetal scarless healing amniotic membrane? Well, we certainly know that they're anti-inflammatories, they're certainly anti-adhesive, and that transfers to quite a bit less scarring. So as we have increased collagen types 1, 3, 4, 5, and 6, we see fibronectin, laminins, growth factors, hyaluronin. So in the United States, ophthalmic surgery, general surgery, gynecologic surgery, neurosurgery, hand, foot, and ankle are commonly places. We have over 300,000 cases done so far in the United States. So there's different varieties of this amniotic membrane, and it really comes down to the preservation techniques. So there's a company in the US that does a cryotech freezing process that allows this to maintain the integrity of this extracellular matrix with minimal damage. So it seems to have the consistency of like a jellyfish. It's a moist tissue, and it maintains a very nice handling characteristics. There are other types out there that are stored in a hypertonic salt solution, and then there is some loss of function, quite a bit more dry. They're almost like seaweed type textures you see in sushi. So amniotic membrane, again, cryopreserved, about 130,000 of these at the time that I wrote this, over 300,000. There's 300 publications out there. And what's nice is it prevents rejection. You see regenerative growth, and there's actually a physical barrier, and we'll take a look at some of these. So where do I use foot and ankle surgery, and where is this potential? So oftentimes between the tendon sheath and or sheath in the skin, anywhere where there's raw bone, if we've resected bone, under scar-prone incisions, revisional surgery, things like revisional perennial tendons or posterior tibial tendon surgeries. And it has a nice role with any nerve type surgery, such as tarsal tunnel syndrome. So how is this? Well, we can do a wrap type technique structure, such as a tendon. We call that a burrito technique, where we're wrapping it around the structure. We can use it in between layers, where we would put it, for example, between tendon and sheath in the skin if we need a barrier. And in some cases, we do an onlay between bone and the soft tissue. So there are different sizes, and you can see the sheath here, the sheath in this ankle case, this gelatinous type appearance, but you can see you can suture it intact. It's got some integrity to it. It's not very flimsy. And so here, let's take a look at different foot and ankle applications and some specifics. So primary and revision surgeries, revisional procedures, but even in some of our primary cases that we have where we consider a high risk for scarring, posterior tibial tendon, again, perennials are fraught with lesions, and surgeries such as tarsal tunnel, as I mentioned. Tarsal coalitions is a nice place to interpose to create a barrier. Rigidus, where we're concerned about rubbing and grinding of the bone, Freiberg's infraction, the second level, in some cases in total ankle replacement. So let's take a look at specific areas here. We'll talk about hallux limitus, hallux rigidus. So the first metatarsal phalangeal joint. So we know there's a role. This is an example here of an arthritic joint. Many people would fuse this. You can see that Parekh's amniotic graft there. And we know that scarring is a predictor of limited range of these types of surgeries. Limited range of motion is equivalent to poor outcomes. So wear motion, this is something that we would consider. If we're looking just at our decision-making with chilectomy, we know that we have predictable success with the early of hallux rigidus, stage 1 and 2 under Coughlin-Schernas classification. And then it becomes more arthritic and more sclerotic with marginal. We become more difficult to see good results. So very rarely in 4 this, but in grade 3, if we have greater than 50% cartilage, it is something worth considering. So let's take a look at the results with chilectomy. Coughlin was published several years back, a 9.6-year follow-up retrospective analysis showing 9% of the patients had good to excellent results. It's certainly correlated to the stage. The higher the stage, the poorer the outcomes. If we're beyond the stage 2, see the outcomes begin quite dramatically. Mark Easley had 52 patients. AOFAS scores improved from 45 preoperatively to 85 postoperatively, with the majority of these patients being satisfied. Similarly with Mann and Coughlin, 90% good excellent results. Patient paper by Mullier, 20 high-level athlete, 22 feet, hit a 5-year retrospective look with 95% good to excellent. One of the types of osteotomies to help improve our range of motion and cheat a little bit is the Moberg osteotomy. And with proximal phalanx, we can take a small wedge to increase the relative motion, as well as combining this with a chilectomy to reduce the dorsal impingement. This is a supportive arc of motion. This is a nice option in the younger patients. You can, again, combine this with a chilectomy if you have less than 60 degrees of dorsiflexion intraoperatively. So in other words, if you have excellent dorsiflexion intraoperatively with me alone, that may be sufficient. The other thing you could consider is whether you've got tight distal plantar fascia or tight flexor hallucis longus before instituting Moberg osteotomy. One downfall to this Moberg osteotomy is that it does increase the dorsiflexion of the toe in kind of a cheating fashion. So if you do eventually fusion, you'll have to take that into consideration when you joint in the future. So looking at the results of the Moberg osteotomy, 57 for the 3 with 90% satisfaction, noting reasonable increase in dorsiflexion. So decision making, grade 1 chilectomy, grade 2 as we get into fairly significant arthritic changes, chilectomy, and if we don't have 70 degrees of dorsiflexion on the table, we'll consider a Moberg osteotomy. And then grade 3, fairly advanced bone-on-bone arthritis, and particularly in my hands, if I see the arthritic changes, the central portion of the metatarsal head, the first metatarsal, or extending into the inferior aspect, or if we see significant sesamoid involvement, these tend to have a poor prognosis, and I'm more likely to do an procedure. So looking at the results with fusion, Coughlin is 6.7-year follow-up. They had 94% union rate with 100% reported results. Not only increased propulsion, enhanced and stability occurs all through the medial column of the foot, not just to the great toe joint. Let's take a look at some specific case using the amniotic membrane. So this is chilectomy. You can see fairly advanced stage 2, almost a stage 3 first metatarsal joint arthrodesis with a large dorsal osteophyte or dorsal flag sign. We would call this a parachute technique. You can see where we've probably 20 to 30% of the articular surface hibernated, or the cartilage been eaten away by arthritic change, and we've the amniotic membrane in between the joint, and we will suture that in, but also we've laid that in between the metatarsal head and the sesamoid apparatus from arthritic change to try and create a little bit of a physical buffer or barrier. And see what that looks like in an onlay type of application. So rather than an implant but just an onlay to help improve range of motion, to minimize over the joint where we want to try to improve our range of motion post-operatively. This is an area of the parachute type technique. an interpositional arthroplasty or anchovy type technique. Here's using a Moberg type osteotomy, how that's created with a plantarly based wedge, where you try to gradually feather that so you can dorsiflex it either with screws, small staple, or a tiny plate. Here's an example. We could use this in a revision of a failed implant that was converted to a fusion. This is aseptic loosening and subsidence of a large total toe. And you can see the large bone that's void. So creation there of a dowel autograft to fill in that, and then using locking plate to stabilize the site. And this would be a very nice place to apply amniotic membrane. Chondral D, the first metatarsal meningeal. Essentially, we have a chondral D, which you can see here. And we've treated this similar to what we would do in a talus, where we've removed the unstable fragment and the unstable underlying bone and the healthy bleeding bone. In this particular case, technology, I'm not certain if this is available in India, but is the juvenile particulated cartilage cells. So this is taken from donor cartilage, which is chipped up into very fragments of cartilage. It's essentially put around fibrin glue, and then we lay these particulated cartilage cells over top of that, and then another layer of fibrin glue. And then finally we or do a parachute technique, or even an inlay or onlay type technique with the membrane, which you can see here on the far right. Again, tarsal tunnel syndrome is another place where we're seeing difficulties with postoperative scar. In the US, very few people are doing tarsal tunnel surgical releases anymore because it's brought complications and very significant rate of medical complications here, where a lot of people are being sued over poor outcomes associated with these surgeries. So in these cases, we're looking to have a distinct positive Tinel sign. We love to see a true positive study preoperatively rather than just vague clinic symptoms. We need something to hang our hat on to be safe from a medical legal standpoint on these people. In patients who have discrete occupying lesions, if they have, for example, varicosities or enlarged based extra muscle belly in this case, or for example, some type of space occupying MASH, some type of tumor, these do quite well with tarsal tunnel, and most of these seem to have a very nice full recovery. If there's any damage to the nerve itself, obviously we have variable recovery. And we like to know that we have objective data. The problem is a lot of the neurologists here in the US, physiatrists, which would be like a combination of a orthopedic medicine doctor, and they're quite good with axial skeletal things to getting adequate nerve conduction velocity testing of the distal extremities, and start trying to differentiate the distal tarsal tunnel from first branch of the lateral nerve and differentiating Baxter's neuritis from the distal tarsal tunnel. They have very poor ability to kind of differentiate that. So we're cautious. So how outcomes, we need to have our home runs here. We have a positive Tinel sign, people who have a positive nerve conduction velocity, people who have a definite entrapment, for example, with a space occupying lesion, and an early decompression seems to do better than waiting a long time. And a complete release, rather than just simply releasing the laciniate ligament over the tarsal tunnel, seems to do much better, particularly as we can get distal and abductor hallucis muscle fascia, the deep fascia where it can put. So let's take a look here. Looking at the surgical outcomes, literature varies between about 42 to 85 success rate. Again, often better objective improvements than subjective. Patients still have difficulties. And again, releasing that abductor fascia is important. So you can see here the delineation of the different branches and the vascularity. But of course, that's something that's potentially with issues associated with scarring. Also in diabetic neuropathy here in the US, there are some tarsal tunnel surgical releases being done. This is not a new concept, 20 years of literature. Tinel sign is imperative, so it doesn't seem to do very well in patients who just have vague diabetic neuropathy or sensory neuropathy alone without actual tarsal tunnel type symptoms. So people like Lee Dellen have written extensively on this topic. Success rate varies from 50 to 92%, although there is a higher percentage of these to get pain relief. So early preclinical evidence suggests regenerative properties are quite good, in fact, comparable to in a rat model. And we know that the amniotic membrane has anti-adhesive properties, and it shows decreased adhesion and scarring in the rat sciatic and rabbit ulnar nerve models. So there's data in the animal world. So anterior tunnel syndrome, this is another instance, deep perineal decompression and inlay in the dorsal aspect of the foot. Here's an example of tarsal tunnel release here. The incisions carried down this, and you identify that superficial fascia, and you go reflect down the abductor hallucis muscle. We develop those borders, and we release fascia. We recognize our neurovascular bundle, looking for any varicosities, and looking at else for any change. So you notice a little bit careful about how we do here, not so much digging around, but you can see here that deep fascia as we're reflecting the abductor hallucis muscle down. You'll see if I to that right here, this deep fascia right in that area, and that muscle's kind of pulled down, really compresses down against that nerve here as it kind of traverses into the aspect of the foot. So that's one of the key points. And then pulling the muscle proximal direction allows that neurovascular bundle to move into the bottom of the foot once you've released both on the outer, so we'll release it on this side, on the back side, and release it deep under there. So ideally, you'd like to press your fifth finger slightly underneath that muscle. So proximal for any other fibrous septae as well. Once that's all decompressed and we've branched that all out, we want to make sure there's nothing involving the medial calcaneus. And then we'll drop our tourniquet and make sure that there's no excessive bleeding. This is an example of past Mayo scissors, or Metzenbaum scissors rather, deep to that hallucis muscle as it traverses the neurovascular bundle underneath the foot. And this is where we'll interpret that amniotic membrane inside there. And this is a 57-year-old female here who had a previous unsuccessful tarsal tunnel release distally. Distal tarsal tunnel and Baxter's nerve entrapment. You can see the abductor muscle clearly here with a deep fascia covering over top of it has been sectioned, and you can see the neurovascular bundle. And so we should be able to pull this muscle down now and fascia on the back side of that. And that's really a lot of times where people fall short, is they don't release fascia adequately. So tarsal coalitions, I'm sure in India you see some coalitions. True incidence maybe a little bit higher than previously thought. Look at cadaveric specimens in this study by Solomon, about 12.1 of them actually showed some form of tarsal coalition. And so this is where you can see left versus right. There's clear limitation, talar joint range of motion and mid-tarsal range of motion. These patients often will present with chronic pain after activity. They'll feel a sense of stiffness. There's many patients who go through their entire lives without recognizing they've had a coalition. They may present to you with a flat foot, a symptomatic flat foot as perineal spasm. Or they may simply go through their young adult and at some point sprain their ankle or sprain their foot or have some type of subtle injury that converts asymptomatic tarsal coalition to a symptomatic coalition. Definitely, this is taking a look at a middle facet coalition, that obliquity there on CT. Type 4, we have a complete tarsal coalition here in the middle. So what are operative approaches? Navicular bar, should we do a fusion? Should we resect it? And if we resect it, do we need to do? And what are the long-term outcomes? Well, in some cases, we need additional surgery in the future. Typically, people less than about 14 seem to do coalition resection. Beyond that, if we have extensive joint involvement of arthritic changes or secondary changes, in those cases, we may be with fusions. So obviously, we try not to do fusions in young people. We want to take a look at the position and determine if they're correctable. And if we do a resection, we correct adequate position for normal ambulation, or should we be moving? Again, degenerative changes secondarily. And who's the ideal candidate? Well, if less than 20% of the joints involved and there's no arthritis or no significant deformity, and if you're able to correct it with periarticular osteotomies, doing things like an medial osteotomy is a very popular approach here in the US, possibly a medial calcaneal displacement osteotomy. Even in the same setting, we oftentimes do both. I had 2 cases yesterday of a combination of both the medial calcaneal displacement and Evans lateral lengthening. So what are the outcomes with a talocalcaneal joint if we're actually facet? Again, the middle posterior facet's a little harder. Middle facet seems to do much better. 50 to 94% do good to excellent. Interestingly, beaking, which is confused with arthritis, which is not arthritis. There's no correlation with outcome, so that's an interesting finding. So what's the using a membrane in tarsal coalition? Well, again, postoperative inflammation is reduced, and we reduce the scar. We want these patients to have early range of motion. We want to maintain good range of motion and avoid any restriction. Works very well as an interpositional material, which alternative to things like extensor digitorum brevis muscle interposition or even fat. Let's take a look at this tarsal coalition case here. We can see Bruce Cohen here, middle facet, very nice image. This is approach locating the middle facet. Sometimes that can be a little bit difficult. Flexor tendons immediately in the region of the sustentaculum. One cheater way to do, if you're not very confident with the area, you can a Kirschner wire through the sinus tarsi, through the lateral approach, and push that through the medial. It'll come through almost directly in front of the middle facet. See here, pre-resection, what that looks like on the left, where we just got a solid sort of bony block. Post-resection is that's taken away, and you can see the articular surface available now. So this is all kind of a bony material. So once this is all here, but at the same time trying to preserve that underlying almost articular layer for the vacuum that allows the flexor tendons to glide. And here's the position of this amniotic membrane into that resection site. So long-term follow-up, you can see this particular patient has excellent range of motion of the joint, and so much so that you can see her beautiful boots there she's now able to wear. Let's see if I can make that play a little bit better. I had to, she came into the office wearing these high-heeled boots. Quite good range of motion here. Calcaneonavicular bar resection. This is an example of somewhere where we're interposing the extensor digitorum brevis muscle. So dorsolateral incision, we take this large trapezoidal bone, we take that out, and we want to maintain that area because it does have a tendency to try grow back together. So we want to do a very generous resection. And then again, here this amniotic membrane placed into all those crannies to prevent a physical barrier. Interestingly, we do see a fairly of wound issues using extensor digitorum brevis muscle and bone wax because of the bleeding associated with the EDB. Graft can be there again, and it can also be combined with the extensor digitorum brevis, but have fairly good outcomes with that. So Achilles tendon surgery, tendinosis is a big challenge. So when patients fail 3 to 6 months of non-operative chronic tendinosis with peritendinitis, we typically do excision of diseased tendon. And we take the full thickness central core of degenerative, and then we excise down to healthy tendon. And this is an example here of diseased central portion, and then doing an inlay graft with this amniotic membrane to reduce adhesions, and then it's just sewn over top. Here's an example of a graft after this has been centrally excised, the tendons, and then the graft is laid on top of that. Perennial tendon surgery, effective for non-operative treatment of peroneus brevis tears. We find these often as a finding on MRI. Many times patients come to us with some other vague complaint, and we notice an incidental finding of a peroneus brevis tendon. Most of these people seem to have non-operative treatment initially for several, But eventually many of those people fail, particularly if they have hindfoot malalignment where they get continued degenerative. Many of those are not traumatic in nature, but just a hindfoot malalignment such as hindfoot varus where they get a degenerative tendinopathy. So this classification, grade 1 is if it's involving less than 50%, grade 2 if it's involving more than 50%. Perennial longus tears tend to be a little bit less common. We see these in different location in terms of symptoms. The perennial brevis oftentimes in the retrofibular groove, slightly distal to the tip of the fibula, whereas the perennial longus tends to be in the area of the perennial tubercle or just slightly on the lateral wall of the calcaneus, and also the area under the cuboid groove where it dives into the bottom foot. And these patients will have pain and weakness with range of motion and eversion of the hindfoot or in the first way. Painful os perineum syndrome. This is sometimes a bit difficult to treat, and difficulty in some cases. We'll see this oftentimes combined with perennial longus tendinopathy. The os perineum becomes symptomatic, and you need to decrease the tendon as well as remove that pathologic os. Here's a os perineum with a perennial longus tear, and this, you can see, is a transfer of longus to brevis and interposition between the two tendons there. Perennial subluxation, this is a very common thing that we see associated with skiers and snowboarders here in the US. You can see a superior perennial retinaculum is a little bit looser from chronic injury. The tendon is repaired in a tube fashion after debriding it. The superior perennial retinaculum is repaired over top of the amniotic membrane, which we can see here. So we'll repair this entire, oftentimes with a fiber sutured tape as well for augmentation. This is the parachute type technique where we'll oftentimes lay this between the tendon and the skin, where it's pulled in through with this suture material. See if I can get this video to play here. You can see his little suture material here. Sorry, it's running a little bit jaggedy here. I hope you can see that. And here we'll just see as that kind of slides in that little barrier. Neuroma, Morton's neuroma, not commonly used, but certainly, particularly, we have a risk of stump neuroma in 10% of patients where they can be left with something worse than what they started with. Interposition, this is always a difficult Freiberg's. We can do a tilt-up type osteotomy of the second metatarsal for aseptic necrosis, but sometimes those joints are fairly degenerated, and this makes a nice interpositional material, certainly better than an implant. Posterior tibial tendon dysfunction, that between the hardware and the skin, particularly in the lateral column lengthening where we have over the hardware. In some cases, if we're using a plate for Evans osteotomy. Fetal ankle replacement, again, always have to be a barrier, but just almost similar to what Infuse does, where we have cellular signaling. This does the same thing in the area. It decreases inflammation, so it doesn't have to be a physical barrier. Here's a case of a male who chopped the top of his foot with an axe while splitting wood. He came in after being sutured up in the emergency room without recognizing his injury. And you can see here he underwent a repair, the EHL tendon, and then postoperatively, unfortunately, he recurrent rupture when he tripped and fell. You can see that torn through. So revision, and then a burrito wrap with the amniotic membrane. See if we can make this play here. 12 weeks postoperative, we can see beautiful range of motion and no issues with scarring or adhesions, which is after a revision type tendon surgery there. Also some interest in treating plantar fasciitis and wounds. There are quite a few centers here that are using it. This is a patient who had a medial wound follicle replacement. Of course, we know that's a high risk area for wounds. The patient was treated here for looks like about 28 days and then completely healed. Why amniotic membrane? Looking at newer technologies, reduced scarring and inflammation, regenerative 25-year history here in the US, but becoming used, over 300 publications and close to 300,000 implantations to date. Costly technology here in the US. I shudder to they can cost upwards of $2,000 for a graft, $2,000 US. I'd be interested to know if this is available in India at all. Thank you.
Yeah, thank you, Michael, for this wonderful, and it was really inspiring, but the cost is a major limiting factor. And we have a few questions. One question from Aditya Agrawal, and he's asking about the allergens from this method. Do you have any incidence of allergic reaction?
That's a great question. I've not seen a single incident of allergic reaction after truthfully. No evidence of that.
Okay. And have you observed any properties in humans, as you have shown that in animals they have shown the properties in rats and everything?
Yeah, the data is not strong regenerative properties. But of course, if you're looking at things like ophthalmic surgery, there's quite a bit of literature regarding the eye and some promising results.
Okay, and how do you compare the results with the Cartiva in Helix rigidus?
Yeah,
Cartiva, the synthetic cartilage.
Very interesting. Is Cartiva available in India now?
No.
No. You know, I think we were all very excited when Cartiva came to, especially with this level 1 study that came out from people like Alistair Younger. You know, I ran into Murray Penner a few ago, I guess about a year and a half ago now, and he told me he'd stopped using it. I have Cartiva cases myself. They're all still in. I have no explants at this point. But with that said, Cartiva is completely losing favor here in the US. I think that product is not long to be in the armamentarium, you know, up-to-date foot and ankle surgeons. I gave a talk at our national surgical meeting this past year looking at that, and the failure rates are pretty dismal. There's a good paper that just came out of Los Angeles not long ago looking at the failure rate, and it's high. And what we see is you get significant inflammatory reaction or lucency around the implant where you start to get, I've seen cases where they've extruded and come through the top, where they're almost poking through the top of the foot. And we're seeing a huge number of legal cases with this as well. I have a friend who just contacted me and told me he has 6 cases currently that he's defending. Surgeons are being sued over the Cartiva. So, you know, the idea is we're leaving these implants a little bit more proud to act as a physical buffer, but nevertheless, they're just not doing well. And we've even experimented with putting a screw proximal to them to act as a buffer so they can't subside, because subsidence do with them. But I'm not impressed. I would say I've got to leave 3 in there still, and fair results at best.
A question from Dr. Rajiv. Are there studies showing favorable use of amniotic fat graft and bone wax in coalition?
I'm sorry, I didn't quite understand.
Studies which show favorable use of amniotic membrane fat graft and bone wax in coalition excision.
Versus bone wax, are you asking?
Yeah, fat graft and bone wax.
Yeah, so that's what I'm saying is, you know, it's a good, I don't know that it's better. You know, let's be real, it's $2,000 or $3,000. It's an option here in the US. We have to pre-authorize all of these grafts here for the insurance companies, and many of them deem it experimental, won't pay for. So we certainly do a lot of tarsal coalitions where we're still doing interpositional fat and bone wax and things like that, or muscle belt. If we can get it covered, I certainly prefer it. But, you know, we certainly do both as well.
Okay. I don't think we have other questions. So
Michael,
thank you.
question. I have a question for Michael.
Thank you.
Please. Malhar, you can ask.
Yeah, Michael, we in the residency fresh placental membrane over dressings in the in surgical cases.
Oh, that's great. Yeah.
think that, do you think something similar, because that was not sterile, it was just from the gynec, the OBS patient we used to get the membrane. So do you think that sort of a thing could work to the something amniotic membrane which you are talking about?
Well, this is it. It's the placental membrane, right? So I think it's very similar. The question is disease transmission and sterile process and things, and that's always difficult. Okay. So tell me about your success with that. I'm curious to know. That's really fascinating.
I don't get the students in the surgery term at that time they were using it. So I'm not who was directly using it, but we saw them placental membrane for open of the limbs.
There is a comment.
Also, sorry, go ahead.
Yeah, there is a comment with Mehta that it is being used in corneal. So
also here, foot and ankle internet, there's an article not long ago out of West Virginia by Bob Santrock, plantar fascial injections using the granulated placental membrane that's reconstituted in saline versus corticosteroid injection. Found slightly better results with it. So it wasn't strikingly better, but it is something that we're seeing.
Okay. We move on to next talk. Thank you, Dr. Michael.
Thank you.
Yeah, the next talk is by Dr. Rajiv Shah, our own Dr. Rajiv, who is of Asia Pacific Foot and Ankle Council, and is past president of Indian Foot and Ankle Society and managing director of Sunshine chain of hospitals. And I invite take his talk on the patients in foot and ankle in trauma. Dr. Rajiv.
Yeah, if you could share my screen. Yes. I hope my screen is visible to you all.
Yes, very well visible.
Yes, sir. Proceed.
Yeah. So change is the way of life. May it be iPhone, notes, car, or the advertisement. This is also the way of orthopedics. We were going ahead with a prime fusion, and now we have moved to a kind of biological. We at Baroda Orthopaedic Associations had to change. We had one of our speaker who was to speak on sports injury and ankle, Dr. Carlo Borbon, President of Philippines Foot and Ankle Society, who had a medical emergency on his kid and really changed his schedule, and he was not available, and I am proceeding with this talk. So it's time to change. Let's leave the change. Change definitely is a good thing. So that's what I'm going to talk. What are the changing newer trends in foot and ankle trauma management? What is concepts have changed, techniques have changed, and technology has changed. And let's look forward to all this after another. So what are the change concepts in foot and ankle trauma management? Now, is this a or is this an unstable one? Isolated fracture. And we were taught that the medial examination is the key. A swelling on the medial side, ecchymosis on the medial side means lateral malleolar fracture, and it requires fixation. But it is believed that medial examination is unreliable. To do a gravity stress testing or other stress views, sure whether this fracture, which looks innocuous on gravity stress, displaces and there is a medial space. So stress testing is a must to decide about stability of isolated lateral malleolar fracture. A concept about posterior malleolus fixation, that if it is more than 25% of articular surface. Or if the fracture has depression or the stab into the articular surface 3 mm, this requires fixation, may be anterior to posterior or posterior to anterior. Maybe it with a screw. It's changed. And now it is believed that it is not the size of the malleolus. It is the stability of the ankle matters. It is the attached strong posterior inferior tibiofibular ligament, syndesmotic ligament, which requires fixation of posterior malleolus from posterior to anterior and preferably with a plate. Syndesmosis, we have a lot of controversies in syndesmosis, but now it is believed that either for a syndesmosis, either you use arthroscopy, but better would be open reduction where you see it under vision with a 2 to 4 centimeter incision and near the syndesmosis. So this kind of fracture definitely require a syndesmotic fixation in an open way. So for syndesmosis, is go ahead with open reduction. As far as possible, avoid finger for your reduction, and with screw fixation is more preferred. And a reduction is not at the incisura, but at the joint line where Mercedes-Benz sign. So these are change concept for syndesmotic fixation. We were taught that deltoid injuries are to be treated conservatively. We always literature that the acute repair of deltoid ligament is not indicated. But if we see the present concepts, it is said that it is better to address deltoid surgically so that you can mobilize the patient fast and the later date complications. So today, the tune is to repair or reconstruction. Every ankle fracture should be stressed to deltoid injury once you do complete fixation, and it is advisable to repair deltoid ligament in an active individual. Less frank injury, we know that it should not be KY, but we do use to fix it. Today, it is understood that the bridging plates are better screws because these bridge plates not violate articular cartilage of the small tarsal bones and thereby really prevent occurrence of later arthritis. So bridge plates are preferred over the screws. That's a change concept for lesson. Zones fracture, we used to treat it with plaster immobilization, but it is now believed that intramedullary to be used for young, active, and sports population for Jones fracture because it heals with a delay and is fixed in a sportsman or in a young and active individual with the screw. It gives a result. Certain fractures we used to do primary fusion because they were non-reconstructible. Looking at such kind of pilon fractures, advise that they are non-reconstructible and you can go ahead and do fusion. But like elsewhere in the body, primary fusion is not preferred over the primary fusion in non-reconstructible pilon fractures. Considering a case of center 4, I used to believe that center 4 requires primary fusion, but the literature changed the concept saying that try to fix center calcaneus to the best of your ability so that later date fusion over that surface is easier. The another concept change is the midfoot fractures, which were non-reconstructible, should not be primarily fused, but it reconstruct them with a fixation. And that is how in this we did. So like elsewhere in the body, later date fusion is easy, primary reconstruction is carried out for non-reconstructible pilon, calcaneus, and midfoot fractures. United ankle fractures, we were treating it with ankle fusion, but it is said that ankle is a very, very important. As far as possible, try to follow reconstruction, then fusion, like we did in this case. This lady presented to us at the end of with this kind of malunited fracture, which was reconstructed. So reconstruction in fracture, and these are the kind of movements she got after reconstruction of the ankle fracture. So reconstruction of ankle, people have to 3, 4, 5 years if there is a flow arthritis and there is no global arthritis which has set in. So that was respect to change concepts in foot and ankle trauma management. Now I'm going to talk about newer techniques which have come for foot and ankle treatment. So the most in technique is arthroscopy assisted for all intra-articular fractures to delineate cartilage injury, to delineate injury to the osteochondral lesions, ligaments. You need to do an arthroscopy assisted. This female 34 had a road traffic accident, cyclist holding Limca book record, and this is how she had her ankle with a impacted articular depression. This was the CT scan like intra-articular fracture, a high demand athlete. So for her, we went in for AAORIF, that is arthroscopy assisted open reduction internal fixation. The first stage external fixator was in. We waited for the wrinkles. In the second stage, we went in for an arthroscopy assisted open reduction internal fixation. 2 portals were created. How the fragment which was lying in the ankle was fixed temporarily with the K-wire. This is how osteochondral tibia was treated, and then joystick reduction of the fragment followed by fixation with the look into the joint, whether we have reduced it nicely, constructed the articular surface nicely or not. And then final fixation went on. She won the championship of 2018, draw 45 from Assam and came to meet me. This was in 2018 that she started driving her car and a full range of. Another case of pilon fracture, again intra-articular C2 type fractures, arthroscopy assisted internal fixation, and there were this kind of depressions which are lifted up and articular was reconstructed. Calcaneus fracture, minimally invasive calcaneus surgery is now practiced with or weight subtalar arthroscopy. Even open reduction internal of calcaneus is also practiced, added with a dry subtalar arthroscopy where 30 degree scope used, and a fracture line which is used well or not can be identified with the use of anterior and posterior dry subtalar arthroscopy whenever you are doing a fracture fixation. Now this is the case of my fit school. When you have very poor soft tissue, arthroscopy fixation helps you. This was the case of fracture dislocation talus. Talus was extruded out, and the skin condition which was good was on a posterior. So posterior ankle arthroscopy was done, and talus was reduced back. These are intra-articular, intraoperative pictures. 2 posterior screws were passed after doing the reduction, and this is how a bad talus fracture was fixed with the arthroscopy assistance. So arthroscopic assistance helps in precise of intra-articular fractures where you want to delete injuries, cartilage injuries, and detect and treat osteochondral lesions of the. There is another emerging technique. When you have a poor soft tissues for a calcaneus fracture, you could do minimally invasive, and you can augment the size of the bone with a balloon kyphoplasty. And this is, you can push in a balloon, you can expand the depressed bone, you can lift up the depressed articulars, fill it with the cement. And this is really used in the articular depressions in calcaneus as well as midfoot fractures. This is a technique developed by Professor Nunley. Wherever he feels that the blood supply is at risk, he uses vascularized bone pedicle grafts from the form into talus, into cuboid, into navicular. He wants to put it. The valve is dissected and the pedicle is turned like this. Then pedicle is attached to the fractured area. This is a of the fracture, more so into stress fractures whenever it is being into the athletes. So vascularized pedicle bone grafts they help in the reconstruction of talus and navicular fractures, which has very high chance of avascular fractures. Now come to some newer implant which has come in foot and ankle management. These are memory staples. These are Nichelon memory staples. Is that memory, and once you put it into the fracture, compression of particular fracture. People have started using internal brace, that is a mini tight rope for left flank, where left flank fracture compression is done, and the problem of the breakage of the screw or extension of the screw is avoided by using this internal brace. There are materials which are being used for the bone loss. The cages are the one which we use in the spine fracture, and that has been used into the midfoot and forefoot bone loss up with the bone grafts. Now, fibular nails are used into the condition, real poor condition, skin condition, old aged patient, or diabetic patient, where you want to do syndesmotic, you can use fibular nails and you can do this kind of fixation. It's a lot with syndesmotic through the fibular nail. Intramedullary for calcaneus fracture is in war since long. Is the one which really prevents the later date collapse of the calcaneus fracture. That is what is said. Antibiotic implanted nails are available for tibio-talo for infection. So these are some new ones which are available in ankle management. And last, to talk about some newer technologies into foot and ankle management. Very, very important for ankle fracture. Operative. When we think that this fracture is a simple fracture, but it's got injury of syndesmosis, this is how the modern cotton test looks like with the simple innocuous looking ankle fracture. This is antero-posterior ballotment. And even if you use the syndesmosis well, you are really afraid whether syndesmosis is well fixed and malreduction chances are quite high. And so, ideal tool to help in intraoperative 3D, where you can manage intraoperative detect malreductions which may go unnoticed on especially rotatory malalignment. Some intra-articular implant are there or not. Implant is pierced intra-articularly or not. You can detect loose body and detect marginal joint infection by intraoperative 3D imaging. CT scan is available for fixation of the ankle fracture, renowned as in the world, where they do verify syndesmotic reduction before after syndesmotic fixation through a CT scan. Weight-bearing CT scan is another through foot and ankle orthopedics and trauma. Want to have in 3-dimensional texture of 48 which are there in foot and ankle. Want to really know the angles between these lines, slopes, everything, and you really want to understand that how impacted this fractures, and so it has very, very in understanding of less frank injury, more so subtle less frank injury. Injury, again, syndesmotic sprains, very, very important, and some subtle fractures and some stress fracture in foot and ankle. Weight-bearing CT scan is being, unfortunately, it is yet not available in India. In weight-bearing CT scan, you could kind of subtle less frank subluxation and dislocations, and there is now National Weight-Bearing CT Society who extensively utilization of weight-bearing CT in foot and ankle orthopedics. Allograft replacement for fractures where you have a defect being used ankle. Look at this case, road traffic accident in a young adult, a crushing of the foot with pound fracture of the talus, that of the medial dome, had a comminuted fracture fibula. On day 1, debridement was, this was the kind of picture after debridement on the lateral side. The X-ray, when he was referred to us, end of X-rays were put and clinical was the foot and again showed communication into the medial aspect of the talus, which almost looked like medial side of talus. The CT images, again coronal imaging. So for the surgery number 2, where a debridement was done, external fixator was put in, antibiotic integrated cement spacer was put for days of medial antibiotics placed in coaxial. So that clinical image after surgery. And this was a closer view. We put in a VAC application, and this were the X-rays. Fibula was fixed with the 2K wires, and the medial lost part of the talus was replaced with antibiotic spacer. This was the lateral view. Then it went on to heel skin graft for the, and this was at the end of that fixator was removed. Everything looked healed. The patient was taken for a definitive fixation. So what next? Problems like precarious soft tissue envelope, segment short with comminution and bone loss, and 55% of the talar body lost. How to replace? And then there was a shell of the neck with a fracture of the neck of talar to fix. And these all problems were solved. Precarious soft tissue envelope, we went in for a medial approach, and lateral approach was at the end of the fibula. And segmental fibula plus comminution was treated with of the fibular length and a syndesmotic and bone grafting. 55% of the talar body which was lost was replaced with talar. This allograft received. This was the spacer which was removed, into which talus, which was shaped like a lost medial talar body, was kept in and fixed with the 2 screws. And we did match the surface to graft with the ankle surface original bone. Posterior shell of the neck of talus treated with cancellous bone grafting and fixation of the screws. Ultimately, this was the final result. So, replacement is a viable option in foot and ankle trauma with defects. The last part, discussion on which would be to our rescue for trauma and bone loss. And we have 3D images available which can see bone defect. This is the case of a friend who treated this case with a 3D printed cage. Loss of the bone was treated with a 3D printed cage, or a defect or the end was treated with a cage through which and TTC nailing was done. So this was the final result. So this is available surgeon to really use for fusion. But look at this case. I have presented this case before in BOA, so I'll just rush through. This was a case where there was loss due to a compound injury. Patient's relative, they brought talus, this kind of a shape after 3 days, and they wanted me to put it back. I got CT scan of this talus, which was brought injury site, and got a 3D printed total talus prosthesis. This was then implanted into ankle, and this is how the implant went in, and these were the post-operative image. After, we must have done now 7 or 8 total talus, some verification where we have reconstructed the ligaments also. And also, now this is the case where we had a medial as well as lateral ligament innovated into a process. And look at this kind of movements patients get at the end of 3 months after total talus replacement. And after bad injury was treated with total talus replacement was walking at the end of the. So 3D printed total talus replacement is probably the most technology. We do not really know how long would it last, but presently it's a technology is in vogue. And he said this before many years, not the strongest, not the fittest, not the intelligent, but it is the one who is most adaptable to would survive. And that trauma has also changed over a period of years. Thank you very much, and thank you, BOA, for giving me this opportunity.
Thank you, Dr. Rajiv. Wonderful presentation. We have few questions. There is a question from Dr. Asit Mehta, and he is asking, is tight established for syndesmotic fixation? Because in one of the found that some surgeons are giving up because they were not happy with that. Any your side, please?
Yeah, tightrope is getting more and more accepted into fixation of syndesmosis because it's biological fixation. But yes, people have been started using two tightropes in different direction. So far as I am concerned, a choice, if my patient is affording, I am going to use tightrope. The only place where tightrope is not superior to the screws is late presenting case or case where you are trying to reconstruct the malunited ankle fracture where you need a stronger fixation screws. But again, this is a big controversy. This is just my opinion.
Malhar.
The other question from Dr. Sejal. Any grade of acute deltoid injury which has to be repaired? So are there any guidelines regarding which grade should be surgically repaired?
It's a great question. So any ankle fracture, you need to stress that fracture for the deltoid instability. So that should be the dictum. And if you find, there are no grades given, there are no kind of an algorithm given, but if you find compared to the opposite side onto which you have an injury is little more lax, you that are you going to really go in and explore this? If the patient is an active individual, is a sport person, it would always be able to go in, explore the deltoid ligament and reconstruct the deltoid ligament, repair with the tight pent over techniques you are comfortable with. Mostly old-aged patients or patients who do not have such a great kind of level, you may treat such patients conservatively, where the old advice was to these patients into mild inversion and give a splintage for 2 weeks more. Suppose give splintage for 4 weeks, it was advised to give for 6 weeks. The bottom line is the whole world has now realized that it is the deltoid ligament, very, very crucial, and we should try to give anatomy to active young individual.
Doctor wants to know the long-term results of balloon kyphoplasty of calcaneum.
Yeah, long-term results of balloon kyphoplasty are not yet published in the literature, but many of the people who start, they have stopped it because they cannot reconstruct calcaneus into complete dimensional, three-dimensional kind of shape and size. You would be able to lift up or jack up the articular surface, but you may in turn blast the lateral wall more volume of your cement or volume of your balloon than what you really want. So, of the workers who started it have, like I know my friend Dr. Selene Parekh started it with great enthusiasm, and he has now.
Another question from Dr. Nikesh. What are the long-term post total talus replacement?
The talus replacement which I have done, they're all 3D printed total talus replacement. There's only one study which has been published by Selene Parekh, that too of 14, that has got 2 years survivorship. Beforehand, the multiple reports from the Eastern literature, from the Japan, where they showed that survivorship of total talus replacement was up to 5 to 50 years. Mind you, where talus was reconstructed by their engineers, 3D printing technology not used. So far as my cases are concerned, I have it in more than in avascular of talus. So it has a trauma, again 3D printed total talus replacement for trauma is yet been done extensively in Western. So results you do not know. So I tell my patient that we are going to moments we do not know how many months, how many years they would last. Experimental surgery. If you want surgery with that consent, I can go in and do the surgery. So sorry, no results of 3D printed total talus replacement, particularly are available.
There is a question, Dr. Asa. Do we need to syndesmosis if using tightrope, as it's a soft fixation and automatically reduce?
So I think we are here. Use of an implant is one situation. The reduction of the syndesmosis is second. Like elsewhere in the use the fracture and then we put in the implant. No implant gives us that reduction. Tightrope is to be put in as a personal device. So it is to be done and then you are fixing tightrope or screw. You do need to reduce, and that reduction you should be doing under arthroscopy.
Another question is, recommend MRI in ankle injuries in addition to CT scan to know the ligament status?
Not really. The only case or only type of cases where I advise MRI in ankle fracture, one when I see flak of the bone on the. These are the cases which could have injury to the peroneal tendon, which could have injury to the peroneal retinaculum, superior peroneal retinaculum. And these are the cases where you do very, very rarely, if you have a kind of syndesmotic injury in a high ankle sprain, you might require your patient to MRI examination. Sometimes in ankle fracture, also have a fragment at the tip of the lateral malleolus where you want to see whether the fragment has injured your ATFL or CFL or not. That time also you can think of MRI.
In your present, please, Malhar.
Rajiv, regarding total talus replacement, is there a difference between the Japanese literature mentions and the Indian ones?
Yeah. So Japanese initial all cases they did with the titanium, and so their first was with by and large titanium implant. Thereafter they started using ceramic since this came as a very good implant. So there are no comparative studies between a ceramic and titanium. So far as world is concerned, world over, world as well as Western world, whatever total talus are being produced, they are titanium metal, not ceramic.
The use of allografts, what precautions we need to observe while using the allograft, and what special consent we have to take from the patients, and are there any medical legal issues while allograft?
So I will answer the question first. There are no medical legal issues, so that you can use allograft in every patient, whomsoever patient gives consent. There is a special consent which is being taken by authorities who give this allograft. So people get this allograft from Ramaiah Medical College, Bangalore. So they have a fixed format given to them by DGCI, and this consent they're taking from every allograft is being used. Allograft is a very, very important thing. And once they supply us the allograft, you have within 24 hours. So the problem is like you're getting it from Bangalore, and with the lockdown, have good number of flights. You have to send who will go personally take the delivery of allograft, would come down to Ahmedabad and from Ahmedabad to Baroda by car, and then receive it. Once that is delivered, you have to operate and use that allograft within 20. So you might have to start your surgery early in the morning. And before you start using it, you wash it thoroughly with the saline and then dip it saline plus gentamicin solution. So that's what precaution, as a precaution you.
Okay, like while showing the syndesmotic fixation, typically told that clamp should not be used. Can you explain the logic not using the clamp, and what if we use it, what can happen?
Yeah. So what is most important when we are using the clamp is clamp has to be on the surface of the bone. And if you see the image Siam clamp, the tip clamp facing flush to the bone. It should not be anterior or posterior. So that's one important thing. Clamp has to be put in the direction syndesmotic screw or tightrope. So that is posterolateral to anteromedial. So it's fine into putting such a kind of, then the clamp would push fibula anteriorly or posteriorly. Studies which have come up and shown that the clamp could be the reason for malreduction, and so majority of the people have stopped using clamp. If you clamp, make sure that your clamp is properly positioned and fibula do not slide anteriorly or posteriorly. Clamp. Typically, I use clamp for my cases, presenting cases, or suppose I am reconstructing the ankle fracture, to use a clamp. But whenever I'm using a clamp, I do take, I reduce the syndesmosis, put a reduction holding wire, and then I put an anterior blocking, which is flush to the anterior cortex of the fibula, which will allow fibula to slide up whenever I'm pushing whenever I'm a clamp, it is keeping that fibula plus and is not sliding anteriorly. So whenever, if you are using a clamp, make sure that your fibula slide upwards or downwards, because the ballotment of fibula is more, or the anteroposterior ballotment of the fibula is more lateral ballotment. That is what we all know about syndesmotic injury.
Okay. I think any more questions, attendees? Okay, Sejal, can you please?
Yeah. Yes. Thanks a lot. Thanks everybody. And the meeting with one of the few very good. Live as if you were not to die tomorrow, and learn as if you were to live forever. By the famous quote by. And I would like to thank faculty, Dr. Selene Parekh from the USA, and Dr. for a wonderful session on the foot and ankle. And also thankful to the moderator, Nikesh and Malhar, and very much thankful to Rajiv for sharing the excellent knowledge and motivate us to walk on our own feet to the success. Thank you, everybody, and thank you, Farmed, and thank you particularly to the Mahesh Bhai, Dr. Bakshi, Rajesh Bakshi, Dr. Anil Bhai, also in session, and thanks Team BOA, and thanks to all. Thank you very much.
Need just 1 minute. Yeah. Yes, sir. So, Farmed, I would like to thanks to Baroda Orthopaedic Association and all the dignitary association, and also the guest speaker. So, conveying my sincere thanks for giving us the platform. Thank you.
Closing.
Yeah.
Yes.
you.